already studied about how does the heart function as a pump and how do fluid dynamics in the pump impact cardiac performance. And I'm going to start with some basic concepts, and then as we get comfortable with the basic concepts, we'll go into some very specific clinical scenarios. So I have 3 talks, and we can do all of the talks in each session, or if you want, we can meet again on the different sessions and do different talks. So I'm going to talk about hemodynamics for cardiomyopathy, hemodynamics for valvular heart disease, and hemodynamics for acute coronary syndrome. And if you're very advanced and you don't want me to move along, we can do all of those things in one talk. It's up to you. So we'll start slow and you tell me what you want and we can adjust. So who understands what a Frank-Starling relationship is? Is anybody comfortable with that idea? Does that make sense? Has anybody heard that before? So it's a basic fundamental principle of how a pump works. So given a certain blood pressure and given a certain cardiac performance, the ability of the pump to eject blood is directly proportional to how much fluid is in the chamber itself. So as the left ventricle fills with fluid, and the terminology that we use in cardiology is left ventricular and diastolic pressure. So the more I can fill the heart at the end of its cardiac cycle, the more stroke volume, the more the heart will eject, the higher the cardiac output will become. Now this relationship is not linear. As I increase the filling of the pump, the cardiac output increases, but at a certain point, this relationship will result in a plateau. There's only so far that you can fill the pump before you plateau. And does anybody understand why that is?
Because of the pericardium as well as the contractile of the myosin and actin.
Exactly right, 100%. So you get a star for the day. So the myosin and the actin filaments, the way they work is it's a ratcheting mechanism, right? So the idea here is that there's an optimal relationship between the myosin and the actin. So if it's like this, it's not very efficient, right? If we have it like this, it's very efficient. If you have it like this, it's too much and they can't connect. So that's what this plateau relationship is showing. So there's a limit to how much you can stretch the heart before you lose performance ability. Okay? So that's number 1 principle. So clinically, give me some examples clinically of situations where the heart would be underfilled. What are clinical scenarios where a patient will have an underfilled heart, less preload? The term we use is preload. So what will cause preload to be low in a patient? Hypovolemia is the main issue. So shock is a term that we use a lot. Shock can be caused by low volume. Somebody is in a car accident and they're bleeding and they're in shock. So that will cause the preload to go down and their cardiac output will drop because there's not enough volume to fill the ventricle. What other very common clinical situations that you might see in an emergency department will result in low preload?
Dehydration.
Anaphylaxis is a great example. So somebody had one of these candies and they're allergic to nuts and they don't realize it and they have an allergic reaction that causes all of their blood vessels to dilate, and once the blood vessels dilate, the fluid that's in your circulation ends up in the tissue, and there's no fluid to go to the heart, and the preload will drop. So that's another example. And there's another very common example of shock beyond that we see on a daily basis, sepsis. So somebody has a bad infection, they have a ruptured appendix, and they're in the hospital with sepsis. Sepsis also causes the blood vessels to dilate and the fluid escapes the circulation and ends up in the tissue. If the fluid is not in circulation, the preload will drop and the cardiac output will drop. So those are great examples. So these are very, very common situations that will affect cardiac output. But let's say that the preload is fixed. We have very stable volume. What other things can impact cardiac output if you have steady volume? What other things can you impact that could have a positive or negative effect on cardiac output? Contractility is one of them, and the other one is afterwards. So we'll break that down. So this next slide This is a slide of somebody with very steady preload. The filling pressure is stable. They're getting enough volume, but you can still affect the relationship. And the relationship in this way is being affected by afterload. And afterload is the load that the heart is being placed under as it's ejecting the blood. So the other term that we use for afterload is the blood pressure. So the blood pressure is what the heart has to fight against to eject the blood out of the heart. And the higher the blood pressure, the higher the afterload. The lower the blood pressure, the lower the afterload. And so, what are interventions that can be done in the clinic that can affect afterload? What are common things that we prescribe? What's that? Yeah, so blood pressure medication is a great way to impact afterload. What about the anaphylactic patient that shows up in the emergency department? What can you do to affect their afterload? What are drugs that you can give a patient that has medicine? You can give drugs that can affect inotropes. You can give drugs that affect afterload directly. So a good way to differentiate the two is, what's the most common drug that we give a patient who's having an allergic reaction in the emergency? Adrenaline, right? So adrenaline will cause the blood vessels to squeeze, which is what causes afterload to go up. They also make the heart muscles squeeze harder and squeeze faster, which makes the contractility go up. So those are other ways that we can impact cardiac output. And that's really what these curves are showing. So this is a curve of fixed preload where we're adjusting just the afterload. So you can affect the cardiac output simply by affecting the afterload. Or you can leave the preload fixed and you can affect the cardiac output by affecting, the term we use is inotropy, but what inotropy really means is how strong the heart is squeezing. So those are the two ways that you can adjust cardiac output when the preload is fixed. So there's three parameters: preload, afterload, and contractility. These are the three things that will have an impact on the rest of the discussion. So any comments or questions or issues with those concepts, or is that pretty straightforward for everybody?